from Australia. There will be a segment on surgical use of these devices by Dr. Carson Howard, a surgical specialist here in the United States. And I will go ahead and turn the time over to Paul.
We then considered what an orthotic would do to lift the arch. It would actually cause more weight bearing and more force to occur on the lateral aspect of the foot and potentially make the foot look better, but overload the lateral column and place that at risk of injury. How many times have we seen a patient with pronated feet with orthotics and seen that the lateral aspect of the shoe, particularly the toe box area, has been blown out because of the force placement being too lateral? So plantar pressure gives us the vital information we need so we can make informed decisions based on objective data and give us confidence in our treatment strategies. So force is not something mysterious. We know that because of gravity, our body weight is pushed into the ground, creating forces. And then there is a reflective ground reaction force, bringing force from the ground into the foot. And it's those forces that can overload tissues and cause injury. And this was first found in about 10 years ago in a study done by Williams and Maclay Davis, looking at the effect of inverted orthosis on lower extremity mechanics in runners, where they tested orthotics and how they affected the foot, and the only statistically significant outcome was the how orthotics affected the placement of force. There was almost no effect on kinematic data that they found in their research. And since then, there's been several other research papers presented with showing the same findings. So these forces are mediated through our skeletal structure and also are supported by connective tissues. And working together, the forces are spread through a network so that the forces are distributed so no tissue becomes overloaded. If we have misalignments or asymmetries, as most of us do, these force pathways can go through different structures, placing them at risk of injury. So we can see on the picture on your left, a person with genu valgum or knock knees, where the force is coming more medially to the subtalar joint, causing subtalar joint pronation, where on the right, the forces are more laterally. Now this is a bit more complex because the foot will compensate by pronation as that is the default movement. So it can either cause the foot to pronate or supinate. The question is, we don't know until we have a pressure mat or a pressure plate to show us. Fortunately, this system is managed by the body using our neural system to coordinate the body's joint range of motion, muscle strength, and the elasticity of the soft tissues so that these forces are distributed either by timing or surface so that no one area of tissue becomes overloaded. If there is a reduced capacity of the body to compensate from dysfunction of those tissues, or those systems I should say, that is, if the joint range of motion is less than normal or the muscles are tighter than normal, greater loading will occur in the tissues, leading to a higher risk of injury. So the question is, who does this force affect? And the simple answer is everybody. As soon as you start standing up or walking, the forces we're talking about affect you. So force plates and pressure mats are designed to be used by everybody, not just sports people. That's the key message I'd like to put across. So, because so often we talk about biomechanics and this sort of analysis in regards to athletes and sporting personnel, but it is still as relevant to people who come in with that calce or corn underneath their foot, or people who have diabetes or arthritis, people who've had a stroke and their balance is not so great. Obviously people with musculoskeletal pain, and that could be a child all the way to a great-grandmother. And of course, if you've had surgery or had rehabilitation for injuries, we want to know objectively how the forces are going to be affecting your foot and how we can improve and stop the overloading of tissue so they can heal better. And of course, people who are risk at falls, we can look at the balance and the pressure underneath the foot to assist in that as well. So it can be used in almost everybody you see in your day-to-day clinic. So how do people get injured? We know that people who have acute injuries of rolling their ankle during sport, that is pretty straightforward. But what happens to about a person who comes into your office that has had a pain that's just occurred, they have no idea how it's occurred, but it's really affecting them? How does that occur? Well, it tends to take a long time, and it is a process. The first part is there might be a structural misplacement of force. So in this example, I'm going to use tibialis posterior tendon dysfunction as an example. So let's just say a person has born with the genes that develop an external tibial torsion and genu valgum position, and they also have ligamentous laxity or hypermobile joints in their feet. And as they go through their growth phase, there's overloading of joints and soft tissues, but they're young, and so apart from a few aches and pains, it's not a big deal. But from that, from the excessive pronation, we have gait and postural adaptations, things like a forefoot supinatus or a dorsiflex first ray. This then continues further loading and further dysfunction to the tissues, placing them at a very high risk of injury. And as they get older and their tissues become less elastic or strong and joints become less mobile, those loading forces get to a point where you have tissue failure and inflammation. I'm sure that this is not something new, but it's understanding the pathway that we can intervene through various times through their life to get the forces into the right place at the right time in their feet and lessen their risk of injury. So that's our first section, and I welcome any questions that you might have. Kendon, how we go with questions?
We have a few questions here. First one, if a patient has a cavus foot, how does that affect the force?
If a person has a cavus foot, the force usually will go laterally. In fact, as a very general rule, if you have an internal tibial torsion or you have a cavus foot type, the weight will be forced laterally. But it does depend on the mobility of the joints. You can have a cavus foot non-weight bearing, but if you have hypermobile joints, when that same foot bears weight, the foot can actually become a pes planus. So really, we need to look at, if the foot is a rigid pes cavus, then the weight will go very much laterally, and our focus will be bringing the weight bearing medially. But as a general rule, if the foot is a cavus foot and there's internal tibial torsion, which often accompanies it, the force will go laterally.
Second question, where does the force go in a flat foot?
Okay, well, that's a bit more complex. As I said before, the body compensates for various misalignments and asymmetry, and the default compensatory movement of the foot is pronation. That allows the medial column to be mobile and adapt to the ground surface. So the body uses that to share the load. So a person with a very pronated foot with a very mobile medial column may actually have the weight bearing going laterally through the foot because that's the stable part of the foot. But also it's very common to see the weight bearing going through the second and third MTP joints and out through the IPJ of the hallux. It really depends on a number of factors. And because of it's a compensatory movement, it really depends on other factors that we can use as tests to work out which, where it's coming from and why it's coming from. But the pressure mat will provide data that gives us real clear clues of what to look for in associated with the colours that are presented on the pressure mapping. I'll talk about that a bit later in the case studies.
The next question was, where is the ideal force placement on the foot?
Okay, so there's been a good research paper on that was done some years ago, but has never been argued against. It was done by Bojan Moller, which looked at a concept of a high gear and low gear of how the force or the loading goes through the foot. And essentially, it travels through the lateral aspect of the foot and through metatarsals 3 to 5, because that's the easiest and most energy efficient way of progressing the weight through the foot. So think of it as a low gear on a bicycle or a car. It's very easy, but you don't go very fast. So to get speed, you then transmit that force from the lateral aspect through to the first and second metatarsal that gives you greater efficiency of push as you step forward. So the idea is that the weight goes through the lateral aspect of the calcaneus and the lateral column, and moving through the parabola of the metatarsals ideally will go through the great toe joint and second MTP joint as a person steps forward.
Thank you. The next question, at what point do you consider asymmetry to be causing pathology?
That's a really good question. A lot of the time we will see people with pronated feet and expect them to have injury. You can have a very low arched foot, and if your joint range of motion and muscle flexibility and strength is adequate to maintain that low arch shape, then you are at very little risk of injury. Where with the same foot, if you had restricted range of motion through the midfoot and forefoot, or substantial tightness in muscles or weakness in muscles, such as in the posterior groups in the legs, or the gluteals, hamstrings, and triceps surae, you can be at high risk of injury. This is where plantar pressure mats can really determine whether the force placement is in the right place at the right time, irrespective of what the foot looks like. And that's, again, going towards that study that I mentioned before. It is accurate to use kinematics to look at hip, knee and ankle, and look at the angles and compare one side to the other against norms. And that's reasonable and accurate and is shown to be reliable by research, but actually using the kinematic data of deciding where or how the foot is working, but it's been shown not to be as reliable as kinetic.
Thank you. I think that's it for this section. Again, if you have questions, you can type them in at any point in time, and we'll answer them at the next segment of question and answer.
Okay. So a reasonable question could be asked, what can plantar pressure analysis offer my practice? And there's a number of answers to that. It can provide a point of difference where you show objectively how much you care for your patient's health and turn them into being raving fans of your practice. it can be a point of difference where you can show your difference to all of the other podiatrists and other health professionals in the area. But it can also provide you with amazing confidence of your treatments, and more importantly perhaps, your patients, giving them the confidence that your treatments are valid and worthwhile. And we'll go through this. I mean, I know that plantar pressure systems in the past have been used as marketing, and I've seen some pretty amazing claims. But equipment with high-resolution sensors, like Sensormedica's pressure analysis products, with good software focused on diagnosis and treatment, can really be used to improve the outcomes to patients, which I'll show you through this presentation. So, the first thing we will have a look at is looking at this confidence. So what we can see in the left foot in this presentation is a couple of things immediately which by the naked eye you just could not see. So the first thing we can see here is the functional hallux limitus that is occurring with the high pressure underneath the IPJ and the first MTP joint. We can also see the white line, which is the centre of pressure mark, which is an average between the loading of the tissue from gravity and the reflective ground reaction force. We can see that there's a wiggle in the midfoot. If we look at the graphs in the centre, which is called pressure versus time graphs, we can also see in the blue line, which is representing the weight bearing through or the loading through the heel, that it's not a nice smooth curve, it has a plateau there. This sort of information will really give us key insights into function so that we can make informed diagnostic opinions and hypotheses and treatment outcomes. And this is the sort of thing, the reason why we have ultrasounds and we have ECGs to actually give data on what we can't understand otherwise. This really does give us an insight into the dysfunction of the midfoot joint complex, and we can be confident in what we're seeing because this is objective, repeatable data. This is not something that is what we think it is. This is just objective data, yes. So it's well known how important plantar pressure data is in diabetes and arthritic joint degeneration, but also in surgery. And at this stage, I might hand over to Carson.
Right, so I wanted to bring this one up because this is a personal patient of mine that had this cavus foot before surgery, and this is what he came to me with, a really bad cavus foot in my opinion. He was only middle-aged and in his late 30s, and you can see here there's already a talar tilt to the calcaneus there, quite a bit of osteophytes in the ankle joint, and he was in a lot of pain. So what we did is we ended up taking him to surgery, and you can see on this one here, I'll just show you real quick. This is what I did, is I did the calcaneal slide, reversed calcaneal osteotomy. The 2 screws went in there, and then I did a dorsiflexory wedge osteotomy of the first metatarsal, as I found with the Coleman block test that his first ray was a big part of his cavus foot. And then afterwards I had him walk across the platform to see what it did. So what you're seeing here on the left is what this foot was like after the surgery. Okay, let me explain this here. So just make this understandable. The right foot and left foot both have the same problem. What you're seeing here is that the right foot has not had surgery yet, but the left one already has. So the right one's the one we're going to follow here, because the same procedure was done on the left that was done on the right, to help you just get an idea of what was done. So you can see kind of here on the right one, for example, how much pressure goes to the first metatarsal head, and really how much that pressure right there was affecting his cavus foot. So we did the procedure as you see here, and then I had him walk across it again. And now if you look at the right foot, you can see that just by sliding the calcaneus underneath the tibia and by elevating the first ray, you can see how much the shift changed. Where it was centered under the first metatarsal head, you can now come and see how it's dispersed pretty evenly across the entire metatarsals. And now the center of pressure is more, a little more medial than it was before, as he's more balanced here. And this was nice for the patient because he was still having ankle pain, because you could see how many osteophytes that was in there. He still probably had he still had the talar tilt and the talus, but I was able to come here and at least show him post-operatively the effects of what that surgery did in distributing the pressures and taking the pressure off that first metatarsal head. So this is just one example of how preoperatively and postoperatively we can use surgical cases and use this platform with them to see how effective our work is going, and to show the patients exactly what was done so they can understand it as well. And then at this point, now that I know the differences, I can come here and say, well, if there's anything we don't want or we want to change, we also have this data here to start working on continued care for this patient post-operatively.
Thanks, Carson. We all know the situation with diabetes and worldwide becoming worse, and how uncontrolled diabetes can lead to some pretty substantial and drastic changes in feet. And plantar ulceration is something we all have to deal with on a daily basis. So we all know, in fact, a study has recently been put out worldwide in regards to the importance of plantar pressure and offloading. The question is, if we don't use a plantar pressure analysis, how will we know how much pressure is being placed in what areas over the foot? When we offload an area, we onload the remaining area. So how do we do that without overloading other tissues? And if we don't know how it was initially, how do we monitor whether our offloading strategies are working and working efficiently, apart from getting the patient in week after week after week and just managing their diabetic ulcer? A simple walking over a mat, taking somewhere between 5 and 10 minutes, would give us enough good data to look at the timing of the loading and the peak pressures underneath the foot to make informed decisions. That data would also show where the other high pressures are under the foot and where we can, with confidence, offload the pressure to and make sure that we're not overloading other tissues. And we can monitor on and review how the foot is working objectively by reviewing and comparing the plantar pressure data sets. This is a key sort of use of this system and can be a real game changer, because it takes out the uncertainty and it basically gives you a chance to show the patient how your therapy and treatment is making a significant difference. With all equipment, there is a learning curve of taking on the theory, then applying that practically, but the results are truly worth it. And I'll talk about giving you a shortcut to understanding and making sense of what you see later. We all know how important accurate data capture and collection and repeatability of the data is how important that is. The question of accuracy relates to the examinations and how the data is captured. But you can see with the pressure analysis already that because of the way the data is collected, we can see and we can get values onto that, making the decision-making process significantly easier than if we used a video analysis to do the same thing. Then there are time pressures of the daily schedule of seeing patients and all the paperwork required to fill out all of your notes and record all the data you're seeing. If we use plantar pressure for analysis, however, this can be achieved relatively easily and quickly. So actually achieving the data can be achieved usually within 10 minutes, and the information is such that substantial notes are not as necessary because we can actually see the numbers. We can also see that we can get, the software enables us to place all of the data in one silo of information. So you can use your data capture for a treadmill or a 3D scan or a dynamic mat or a balance or video all in one area, and you can all bring that information up and compare it one to another. Again, considering how you use data to analyze and compare and contrast, this is gold standard. It just makes our life so much easier. Using the data, we can also then start creating a hypothesis. We might start to think, okay, well, these tissues are being overloaded. If I changed where the forces were going, then maybe that would make a significant difference. So we can then, once you've done the initial examination and you've got a baseline of function and where the tissues are loaded, you can then intervene in the clinic by taping or padding and having the person walking over the mat once again and doing a real-time pressure analysis. So for example, if we had a person like that picture with the diabetic ulcer, we'd walk the person over the mat, see the high pressures that were under the ulcer and any other area, then tape a pad onto the foot and walk them over and see if the timing and the peak pressure of that force has been reduced. And then we could say to the patient with confidence that we are improving how the person is walking. We might use the taping to improve the function of the midfoot and the forefoot, and we'll talk a little bit about that later. We could use it padding on the heel to make the heel weight there for a longer period of time, so offload the forefoot with a person who has metatarsalogia. There are so many ways you can test your hypothesis and see whether it has made a difference. So let's just say you've done that and you want to see if what you have done has made a difference. The software enables you to do that. So if we have a look at the right foot, we can see the weight-bearing areas of the right foot is on the left side, is right across the foot in three major pressure areas, and by taping, we've now been able to reduce the pressure to just underneath the great toe joint. Now, so long as this is a functional sort of thing, so that we're seeing the weight bearing going onto the great toe joint with normal function, this is now not a pressure area, then this is a correct situation. So we can actually say with confidence that orthomechanical intervention will make a significant difference, not in just redistributing pressure, but actually improving the auto-supportive mechanisms of the foot to get stability through the rear foot, midfoot and first MTP joint so it can weight bear, so the heel can come off the ground efficiently, the wingless mechanism can work effectively, and the person's gait has improved substantially, not just for the short term, which offloading can do, but the long term because we're improving the actual function of the foot. One of the great things we can do with the software is we can demonstrate what we're doing very quickly by just pressing a button and having a printout either come out of our printer or be saved as a PDF that we can then pass on to other people. So if you're talking to a colleague that is familiar with pressure data or understands human movement so that you can explain it, then something like this report is very easily obtainable and can be presented very quickly. If you are trying to do that with a video, that would take reams of explanation, and because it's subjective, what I'm seeing may be slightly different to a person who's less experienced. So it's very subjective. What we're seeing here, we can see immediately where the pressure is, the timing of that pressure, the symmetry of that pressure is very clear. However, sometimes when you're working as a team, you'll be talking to people who are not so familiar with pressure mapping or pressure data. In this case, we can look at another report, again, that the software will generate immediately for you, that looks at numbers. So it looks at percentages, looks at timings, and looks at loadings of tissue. And this is real data that we can present, then have another team member provide some sort of treatment, maybe in a rehabilitation sense, maybe looking at altering a person's gait, whatever's the case, maybe surgery. And then we do another gait assessment at a later stage to test what changes have occurred, and we can see the changes immediately presented as numbers, and that can be put into a report as so that numbers can be compared. The other thing about these reports is we can see what other factors can occur. So you might do a surgical procedure on a person's foot, and it may have some good outcomes, but some unexpected outcomes of how it's affected other function of the foot. It may be that you've improved one area, but another area has changed that is not so good. So that'll be reflected, and so as Carson said, you can use the data then saying, okay, we've improved one step, now we're going to look at improving the other areas. All driven by data rather than just looking at what the patient's symptoms are. And that gives you confidence because it's objective. And it's the sort of thing that other bodies will be interested in, like health rebates and so on. So now it's the time for questions, and back over to you, Ken.
Okay, first question is, on a diabetic foot, how much pressure reduction do you try to achieve in order to properly reduce the forces on the foot?
Well, that's the magic question, and unfortunately, there is no one answer to that question. There was some research, in fact, the only research I'm aware of that was done some years ago again by David Armstrong about how much pressure in a diabetic foot is too much. And they did quite a great study. It's worthwhile. If anyone's interested, I can provide it. And they looked at a cohort of people at high risk feet, with high risk feet, and they found that 70 Newton meters of force, which works out to be about 11 kilograms per centimetre squared or thereabouts, was too much for 70% of the cohort. That was the level of the point where it was injured. But it's more, like so much of medicine, it's more complex than just one number, because it's not only how much the level of force is, it's how long that force is applied to the tissue, causing hypoxia, that is squeezing the blood out of the tissue, that can cause or contribute to cell death. So, to answer your question, which is a great question, is if there's an area of high risk, I try and reduce as much of the timing of that pressure and the peak pressure of that pressure as much as possible, and I use things like initially padding and orthotics and rocker shoes and anything I can to reduce the peak pressure and the timing of that peak pressure, and the force mat will actually show that to you very quickly and very easily. It obviously won't show you how a shoe with a rocker sole profile will work, but that's where we're starting to get into the flexi feet type of product, the in-shoe analysis product, where you can actually look at how an orthotic is actually functioning as far as offloading is concerned, and how a rocker sole shoe will deal with the timings of that.
Next question. How effective are diabetic shoes and insoles when done with a pressure plate versus done without one?
Okay, well that pretty much goes to what I just said. So you can use a pressure plate using felt padding to offload areas, knowing that you're offloading areas that can take that increased load, and be confident in that. And that's super. But to actually then say, all right, I want to transfer that into an orthotic, you can't make the same decision process based on the felt padding, because felt padding, as well as other material, will mould and squash down because of the nature of the material. An orthotic, even if it's a soft orthotic, will react in a different way because of the materials acting in a different way. And when you're talking about diabetic shoes, whether they have a rocker sole profile or the sole itself, that will have an effect on the forces as well. So this is where the FlexiFoot device, equipment, has a real place. So you might use your mat on a day-to-day basis to measure and monitor your patient's data. Can be done very quickly. As I've shown, it can be used as a comparison process to monitor the outcomes and see where a person is possibly at risk, or they've had an ulcer, and then you want to make sure that they're not going to be at a risk of re-ulceration. But if you're in a position of actually acute care and rehab to actually heal the ulcer and re-establish proper function, that's where the flexi feet will come into, because that can give you real-time data of how the effect of the insole and the effect of the footwear on the actual foot function and the high pressure areas. And best of all, it's in the same software, using the same analysis, the same comparison, so you can actually compare it with what you've seen on the mat previously and what you do on the mat further on. So it's not like it's a lot of different systems that you have to juggle and a lot of different software you have to learn. It's the same data silo. And that just, again, makes it really easy to understand and do analysis on very quickly, because the numbers are all working in the same software package, and it provides confidence and ease of use. So, and the key thing about that is, if it is easy to use and very time efficient, then people will use it. It just won't sit in the corner.
Next question. How often do you adjust your treatment based off of what you saw in the pressure scan?
That's also a good question. So in my practice, and what I encourage people to do is, when they see a patient, obviously, like everything, it depends on how acute it is, how long it's been there for, the severity of it. But getting a baseline is really very important. And depending on whether it's acute, where you're just trying to offload and reduce inflammation, then it will be a weekly or 2-weekly basis, because we want to see if, for example, you have an acute ankle sprain or an acute forefoot injury, we want to offload it and provide other therapies so that we start to heal the injury. In a more chronic condition, we actually want to improve the function so that where in the acute phase it might be weekly or fortnightly, so we can work out when we need to change the treatment because it's gone from the acute to more of a rehab. In the chronic, we will do an intervention and then maybe in a 2 or 3 week review that intervention, and if that intervention is going the way we think it is and the objective data is showing that, we'll then start making orthotics or more permanent solutions, knowing that if the body could heal it up and resolve it itself, it would have done so. And that's where orthotics can be really powerful.
That's it for that for now.
Okay. All right, so moving on, what we'll do now is look at pressure analysis for 3 common conditions. There's many common conditions, of course, so I've picked 3. Central cuneiform joint pain or midfoot pain, Achilles pain, and plantar heel pain. Before we actually go and look at the case presentations, I'd like to actually start looking at the questions you would ask when you're using plantar pressure analysis. So the first question would be, what does the pressure map look like? That is, where is the red and green and blue and yellow? Where is the pressure? Now with the Sensimedica program, you can not only just see the colours, but you can actually see the numbers behind the colours. So because it's a high resolution, high definition map that is calibrated, you can actually see the numbers. And so it's not just pretty colours, it actually means data. So it's really important to know where the pressure is, because you might have a situation where you might have pressure shown as red under the 2nd, 3rd and 4th MTP joint, metatarsophalangeal joint, but the question is which one of those 3 has the most pressure. By turning on the numerical view, you can actually see the number of pressure that's being applied into that area. Then we look at where the centre of pressure is going, because that will tell us where the weight bearing or the force is working through the foot. Then we'll have a look at what the pressure versus time graph tells us. Now, this is called a pressure versus time graph, but some refer to this as a force versus time graph. But we have to understand that plantar pressure maps can only measure vertical force. It can't measure horizontal force. No pressure map can. So vertical force is called pressure, horizontal force is called shear force. So that's why we call it pressure versus time. So they're the 2 graphs in the middle. We then ask ourselves, what are the possible reasons that could be causing this, and form a hypothesis based on the pressure you're seeing, and then looking at what tests and investigations that can be done to prove or disprove that hypothesis, and then look at what are the interventions that you could do to actually, again, show whether your hypothesis is correct. And we can do all of that on the pressure map. When I say the functional tests and investigations, we've been very fortunate over the past 15 years or so to have a situation that we now have a number of tests. I know of at least 28 tests that either are very reliable and repeatable or predict function or reproduce function. And that gives us, again, a high level of confidence of what we're doing is going to be reliable and repeatable. So and doing that we can actually see and understand. So one example is the weight-bearing lunge test. which has been shown through research as very predictive of ankle injuries. If a person has got 10 degrees of ankle dorsiflexion, then that is predictive that they are at a low risk of ankle injury. If they've got less, then that increases their risk of ankle injury and how the foot has to compensate for it. And we'll see that in a number of different pathologies. So in knowing that, we have to address the ankle dorsiflexion as part of our treatment strategy, or we won't get full resolution of the problem. So let's look at our case studies. So John, a 32-year-old runner, presented with left foot midfoot pain after a trail run where he stumbled down a hill about 10 days ago. Since then, his foot has felt stiff, with the pain felt on the plantar surface of the arch. The pain can be very sharp and it's worse with standing. Movement of the midfoot joints is painful through the range of motion through the midfoot, and particularly in the subtalar joint, is restricted. Muscle flexibility and strength is somewhat limited, but relatively within normal limits. So having a look at the key features of the pressure mapping, we can see that there's high pressure under the second and third MTP joints, and we can see that there's lateral loading depending on the pain or restriction. But the key thing is the little wiggle in the midfoot of the centre of pressure. That's the white line. What happens is that the weight bearing or the tissue loading comes through the heel into the midfoot to the point of pain and cannot progress because the body will not allow that because it's in a protective mechanism. So the weight actually then reverses and then finds a different pathway through the foot. And that is a classic feature of midfoot dysfunction. And depending on where that curve is, will show us whether it's the medial, intermediate, or lateral cuneiform. And that gives us a real clue on what's going on in John's foot. Again, this is something that the naked eye couldn't see, and while we know that there is some stiffness and dysfunction through the midfoot, because that's where the pain is, we don't know whether it's a ligamentous issue or whether it's a muscle issue or what it is. And you could spend a lot of money doing ultrasounds and exploratory assessments and not really know this, but plantar pressure will show you this very quickly in 10 minutes. Another question we can ask is, what does the pressure versus time graphs show us? Well, the graphs are often steep, and we will see troughs and plateaus because of this dysfunction through the midfoot, and it's often the main pathology will be shown in the midfoot graph. Now the question, what possible reason could cause this? In John's case, it was the injury he sustained. So here is the summary of the plantar pressure window. You can see on the right foot, while it's not ideal in function, it's probably quite reasonable. We can see the weight bearing through the centre of the foot, and even though the great toe joint is not being loaded as we wish, it's probably without a great risk of dysfunction. We're having a look at the pressure versus time graphs. They're the two graphs in the centre of the bottom window, which refers to the right foot. We can see that the blue line, which represents the weight bearing of the heel, is relatively symmetrical in loading. That's on the side graph, the side axis, to that of the forefoot, which is in the green. So then if we have a look at the left foot then, we can see, of course, the little wiggle in the centre of pressure. But if we have a look at the blue rear foot graph, we can see that there's a plateau there. In the forefoot graph, we can actually see there is a extra trough that shouldn't be there, and comparing the midfoot of the left foot, which is the purple graph, we can see it's much earlier and much higher than that of the right foot. So here is a graph that immediately indicates substantial dysfunction through the midfoot, forcing more weight bearing onto the forefoot and very poor function throughout. This type of injury is commonly seen with people who have a forefoot equinus, because the forefoot equinus is compensated through the midfoot, and it places high stress on the cuneiform articulations in particular. This doesn't necessarily mean that the person is going to be injured, but it does mean that the chance of injury is higher than that person who doesn't have such a foot structure. So what are the sort of tests that we would do? If this person presented not with an acute problem, but with a more chronic problem, we'd possibly see a functional hallux limitus there. So a functional hallux limitus test would be quite appropriate. If a person had joint hypermobility, which would of course cause substantial compensatory pronation, a Baton test would be a worthwhile thing to see if it's a generalised hypermobility across the whole body or is more specific or local. Looking at the subluxation of the medial column, we would look for a forefoot supinatus. Talar congruency test also is important to see how congruent the subtalar joint is and how, if there's any blockages or changes there. Looking at the strength and function of tibialis posterior and tibialis anterior, because that's going to be especially tibialis anterior is going to be working directly on the midfoot joints, and so on. Subtalar joint axis, the cuboid alignment test, and the lunge test. These tests will give us really clear indications of exactly what we're looking for and confirm our hypothesis. So our treatment strategies, in John's case, we know it's an acute condition. So we need to address the inflammation. We need to offload the area. So we might use sports taping to stop elongation of the arch and any excessive midfoot pronation. So to offload the ligaments and tissues around the central or intermediate cuneiform. We might do some gentle joint mobilisation and give a targeted home exercise plan. If this improved, but it was still sore, we might look at a more medium-term use of orthotics to get the weight bearing through. And of course, we do comparative pressure assessment, as talked about before, on a regular basis through the acute phase and every about 3 weeks in the more rehabilitation phase. So we'll move on to the next, which is Achilles pain. So an 11-year-old presented to the clinic with Achilles tendon pain around the calcaneus that had been present for a few months. Now it began last summer, speaking as an Australian of course, so this is your last winter, when she was wearing sandals with no heels every day of her holidays and barefoot down the beach. Now she's back in school shoes, and the pain is particularly there when she does school sports or plays basketball, which she does twice a week. The pain can be severe, particularly after basketball, and she says her calf muscle and Achilles tendon feels very stiff in the next morning. When I asked, the mother replied that she'd gone through a substantial growth phase in the last 6 months. So to analyse the data, the questions we would be asking or looking at is, what would the pressure map look like? We would expect high pressure under the forefoot and often very little loading under the heel. Of course, there can be a large variance between test tube to offloading habits. often the centre of pressure is very central. If we look at the pressure versus time graph, we'll see a very small and short rear foot curve with a prolonged and enlarged forefoot curve. And it's usually very fast in transition. Sometimes not smooth at all, but it's very fast in transition. So let's have a look at this. So here we see the blue curve in the middle, in the pressure versus time graph, is the loading of the heel, and the green is the loading of the forefoot, and we can see that the weight of the the loading of the forefoot is much higher than that of the the rear foot, and for a much longer time. If you look at where the blue line starts, which is the loading of the heel, and the green line starts, which is the loading of the forefoot, they're very close together. So the forefoot is almost loading throughout the entire the entire stance phase of the gait. We can see that the rear foot curve has a couple of bumps in the peak of the curve. That's because of the dysfunction through the rear foot, possibly due to pain. And this is, of course, Sever's disease caused by growth phase and the loading of the tendon on the calcaneus. This is a classic presentation here. And this is something that you can show the parents and explain it very, very easily. They'll understand it very quickly. And it's amazing because now you've got something to compare against. So I won't get ahead of myself. So our possible tests and investigations. So again, we want to make sure that the core muscle strength and function is working, because that's going to have an effect on the posterior leg muscles all the way down to the Achilles. We want to know if there's joint hypermobility, whether there's a forefoot supinatus or dorsiflex first ray, what is the soft tissue contracture state, what is the inflammatory state, and again, the lunge test for ankle dorsiflexion goes without saying. All of that should confirm what we're seeing, which leads us on to our treatment strategy. In this case, shockwave therapy is most appropriate. The evidence shows there's Achilles tendonitis. It's quite appropriate. Dry needling of the muscle, acupuncture, a heel raise. Research says it's got to be more than 10 millimetres though. Targeted strength program, maybe a clinical Pilates, certainly a home exercise program, but comparative pressure assessment. So if you're going to send this patient off to a physical therapist to go through a process of soft tissue therapy, maybe some exercise to strengthen up the muscles, to balance the core, you can say to the patient, okay, bring your daughter back to us in 3 to 4 weeks. We'll repeat the assessment. It'll only take 10 minutes, and we can compare, is the treatment protocol that we're doing making a difference or not? And that's really important, because it may be that the inflammation has subsided, but the dysfunction is still there. And if all of your assessment is based on the subjective nature of the patient's symptoms, how will you know whether functionally it's improved or not? And so if you don't, the person may be at risk of, when playing basketball again, re-injuring themselves and having the whole process started again. So by monitoring it, we can monitor it every month to show continual improvement, giving the patient confidence in the treatment. And of course, we can share this detail with the physical therapist or whoever you're using, so everyone's on the same page. Okay, so our last one is a very common plantar heel pain. So Mary, a 55-year-old office worker, presented complaining of plantar heel pain that just seemed to happen and has been present for 6 months, and it's becoming progressively worse, particularly over the last 1 to 2 months. The pain is described as a background ache but also can have episodes of sharp pain, particularly on first weight bearing in the morning and after any periods of sitting more than 20 minutes. The pain does subside, however, after a bit of movement to a background ache. Her activity level is a 30-minute walk every 2 days, and while she has a range of footwear, the ache seems to lessen with a small heel. So what are the key features? So very poor or no first MTP joint loading. However, there could be a functional hallux limitus loading pattern. The centre of pressure is often very central with hesitations through the midfoot and forefoot. In other words, instead of the weight moving forward in a fluid way, it stops and starts a lot. The pressure versus time graph, we will see elongation of the arch, and that is a key finding, and we'll show you that. In fact, we'll show you that right now. We'll talk about possible reasons in a minute. So what we'll do here is we again do the same pressure analysis, exactly the same, and the software can map 5 different regions, which it does automatically. And you can choose to see the loading in each of these regions by checking the tick boxes at the top, on the top left-hand side of the pressure versus time graph. And here we can see the timing of loading of the heel and the first MTP joint. And on the left foot, which is where the pain is, the weight-bearing timing is 307 milliseconds compared to that of the right foot of 145 milliseconds. That means that the heel and first MTP joint continue to be weight-bearing as the foot elongates forward, placing high tension on the plantar tissues underneath the arch, where on the right foot, once the first MTP joint has hit the ground and is stable, the heel can lift up and not elongate. So that elongation is a classic sign of causing excessive loading of the plantar tissues, and in this case, the plantar fascia. So what we can do is using 1-inch sports taping, we can intervene and stop the foot from elongating by plantar flexing the first metatarsal and adducting, adducting the forefoot on the midfoot, and in doing so, stopping the forefoot from elongating. So then once we've done this, we have a person walk over the mat again exactly the same. Now when we look at this, which is the exact same comparison, the left foot is now at 125 milliseconds. Remember, it was 307 before, so we've reduced that elongation substantially. So we can say with confidence that orthomechanical intervention will assist in this condition. We can also see that the pressure mapping has been affected by the hallux having greater loading than normal. So there's a number of ways to address this, such as placing a felt fluffy wedge under the hallux to assist first MTP joint function, and we could retest this over the mat to further confirm our treatment strategy options. So it is a process of understanding what is happening in real time, not just taping the person's foot up and asking them to try it out and getting them to come back with a subjective point of view, because we might solve one problem and create another problem, where this can show us exactly what the good parts and the unintended parts are that we can address immediately. So what can we do about this? Well, we have a look at the test and investigation. A lot of it is very similar. We want to know if we can correct a dorsiflex first metatarsal or forefoot supinatus that may be part of this elongation problem, certainly a functional hallux limitus. We need to see how the windlass is working, a subparajoint axis test, And again, footwear assessment, if the person is wearing shoes that bend in the middle because the sole is not supportive, we need to address that. So this again helps confirm our hypothesis and gives us a direction of where we want to go with our treatment strategy. So again, we need to look at anti-inflammatory therapy. Now, as this is a chronic condition, it will be different in how we deal with the acute. Again, we could use shockwave therapy. Instead of using taping, we might go straight to a functional orthotic because the taping shows that that's got a good intervention result. Soft tissue stretching, targeted home exercise plan, and again, footwear. And of course, we would then review this person again in 3 weeks to see if there's a change. Okay, Kenan, we're up to questions again.
First question, how can I learn more about the center of pressure in relation to various foot and ankle pathologies?
There's 2 answers to that. Take a lot of time and read lots of papers and have lots of experience. Or I'll be presenting in just a minute a way that you can very quickly take on board a training program, an online training program that will teach you the classic presentations like we've just seen here of 24 common conditions. And it's not so hard when you're looking and understanding the patterns. So for example, if you see a classic pattern like I presented for plantar fasciitis or heel spur, it's not that hard for you to make a decision on. But how often do we see classic patterns day to day? There are always nuances that are there that put in other factors, other interactions of other tissues. So it's the understanding the nuances that makes the difference. So for the 24 classic common condition presentations, each one of them have real life examples of showing the pressure mapping and going through the center of pressure and pressure versus time examples so that you can understand the nuances and understand and build up in your own mind the presentations of a particular condition. And once you've gone through the learning, it is then a library resource that if you see a presentation on your pressure mapping that you don't fully recognise but you think is a particular problem, you can go straight to that problem and review, is it that or is it something else? So that's the way to shortcut a whole world of time and energy and resources trying to learn it from scratch.
Next question, how can I use this pressure systems for fall risk assessment?
Okay, so fall risk assessment is another feature that the software provides, where standing on the pressure mat, you can view the symmetry of the pressure loading of the forefoot to rear foot and right foot to left foot. The software then gives you a number of tests and protocols such as Romberg test, sway test, and a number of others, which will lead you through a number of example protocols, so a number of protocols to measure data that you can then have analysed for you to see how good the balance potential of a person is. So with, for example, the sway test with a person standing on the mat, they will stand there for 25 or 50 seconds with their eyes open, then again with their eyes closed, with both feet on the mat. Then we have them stand on one foot for 5 seconds with their eyes open and closed, and repeat that to the other foot. And that will give us a really good understanding of the balance that they have and their asymmetries of muscle strength and muscle weakness, and areas that they can work on. And then once they've gone and done proprioceptive drills or muscle strengthening or any other treatment that is required, we can test it again and do an immediate comparison. All objective, and we can share that with any other health professional we're working with. And I should say, this will only, again, take 10 minutes. It's not something that will take half an hour or an hour to assess, to get a baseline, or reassess to compare.
Okay. Next question. How do I know which system is best for my office?
You're talking about the pressure mats? There is 3 systems available: the 1-step mat, 2-step mat, and a 3-step mat. So a 1-step mat is fantastic for screening. So I have one and I take it to different locations. I use it for sports. I work with football, soccer, and other sports. I've used it in basketball, gymnastics, and using that for the balance proprioceptive assessment is part of what I do, and it's really effective. If you're a soccer player, when you're handling the ball with one foot on the ground, if you are stable on that foot, you can really outrun your opponents very easily. If you don't have the stability, then your opponents can steal the ball from you. So it can be a major factor in a person's playing ability. So that's really good for that. I would not necessarily recommend it for proper gait analysis, because it's really hard to get a patient walking over the mat in a non-conscious state. As hard as you try, they tend to put the foot onto the mat, shortening their stride or lengthening their stride, and you're not seeing a normal stride. And if you're going to do the comparison data, the data has to be accurate and reliable. So this is where a 2-step mat is probably the workhorse of the range. It is a mat that you can take good data from, you can use really good protocols from, and that can be comparable from one assessment to another assessment. Now the gold standard is the 3-step mat, because it doesn't matter how tall you are, you're going to get at least 2 good steps each time you walk over the mat. If you are of normal height, you'll get 3 steps over the mat, hence the name. And that just gives you so much data that the software then can then average for you. And so the more data, the better it'll be the average, and the more you can trust it. So for my money, the 2-step mat is the workhorse, and if you have the room, the 3-step mat is also fantastic. I have, in fact, all 3 of them. The 2-step mat I use for older people and younger people whose strides are shorter, and the 3-step mat I use from people from 17 through to 65 whose strides are longer.
Next question. Can I add cameras to be integrated with the platform?
One of the reasons why I moved to Sensomedica is that it has, out of the box, an amazing amount of capability and what's the word I can say? The ability to plug in various different pieces of equipment and use it in the same software. So out of the box, the system can have 2 synchronized cameras, high-speed video cameras, giving frontal plane and sagittal plane views that are synchronized with the plantar pressure. Now, this is pretty unique as far as I'm aware. You don't have to buy a separate module. It's there as part of the software. So you can also, as part of the software, have 4 cameras that you can use in a static assessment.